Week 6, Placental and Fetal Membranes and Birth. The learning objectives for this week are to describe the development of the placenta and fetal membranes, characterize and discuss risks of a molar pregnancy, describe the developmental variations with dizygotic and monozygotic twins, to characterize common features in the fetus and in the mother in each of the 3 trimesters of pregnancy, and to describe the stages of labor and delivery. The germ layers form the 4 extraembryonic membranes, and these 4 membranes are the amnion, which lines the amniotic sac and encloses fluid that surrounds and cushions a developing embryo. The chorion, which is a double-layered membrane formed by the trophoblast and the extraembryonic mesoderm, which becomes part of the placenta. The yolk sac, which acts as a primary nutrient source, and it's also important for blood cell formation. And the allantois, which later its base gives rise to the urinary bladder. This is a slide showing you the placenta and fetal membranes. Please go to this link in the embryology self-study and look over the formation of the fetal membranes and placenta. A molar pregnancy is an abnormal form of pregnancy in which a non-viable fertilized egg implants in the uterus. It's characterized by the presence of a hydatidiform mole, which is an abnormal growth of trophoblasts. It is rare. It occurs 1 out of every 1,000 pregnancies. The cause is not completely understood. We do know that it is more likely to happen to women who are older than 35 or younger than 20. And some of the potential risk factors are defects in the egg, abnormalities within the uterus, nutritional deficiencies such as diets low in protein or folic acid or carotene, and also if you've had this occur before. This is a picture showing you a molar pregnancy where the early placenta develops into abnormal cysts. There are 2 forms of a molar pregnancy: a complete molar pregnancy and an incomplete or partial molar pregnancy. The complete molar pregnancy is caused by a single sperm. This happens 90% of the time, or by 2 sperms, this is remaining 10%, combining with an egg which has lost its DNA. If it's caused by a single sperm, the sperm reduplicates itself, forming a complete 46 chromosome set. The genotype is typically 46XX, but it can also be 46XY. All of the genes come from the father. In a partial molar pregnancy, this occurs when a haploid egg is fertilized by 2 sperm or by 1 sperm which reduplicates itself. Usually what happens, however, is that it's 2 sperm fertilizing 1 egg, resulting in an extra copy of the father's genetic material. And genotypically, the resulting fetus would have 69 chromosomes or 92 chromosomes. Some of the symptoms of a molar pregnancy are dark brown to bright red vaginal bleeding during the first trimester, severe nausea and vomiting. Sometimes there is a vaginal passage of grape-like cysts, pelvic pressure or pain, high blood pressure, ovarian cysts, anemia, preeclampsia, and rapid uterine growth. In order to do the diagnosis of a molar pregnancy, the level of the human chorionic gonadotropin, HCG, would be measured, and it would be high, and an ultrasound would be done to see if it was a molar pregnancy. And in a complete molar pregnancy, there would be no embryo or fetus, no amniotic fluid, but there would be a thick cystic placenta nearly filling the uterus, and there would most likely be ovarian cysts. In a partial molar pregnancy, the ultrasound would show a growth-restricted fetus, low amniotic fluid, and a thick cystic placenta. The treatment would consist of removing the abnormal tissue for risk of developing cancer at a later time, so a D&C would be performed, and the level of HCG would be monitored to make sure that there is no remaining tissue left in the body. And it is advisable to wait 6 to 12 months before trying to conceive again. Please view the video on molar pregnancy. The time that's spent in prenatal development is known as gestation. There are 3 integrated trimesters, each lasting 3 months. And the first trimester is the period of embryonic fetal development, and during this time, the beginnings of all the major organ systems appear. During the second trimester, you have the development of the organs and the organ systems, and during this time, the body's shape and proportions change, and by the end of the second trimester, the fetus looks human. The third trimester is characterized by rapid fetal growth and deposition of adipose tissue. And actually, early in this trimester, most of the fetus's major organ systems have become fully functional. This slide is showing a 4-month fetus. You can see in this slide the positions of the uterus, the fetus, and the placenta. In this slide, you can see pregnancy at 3 months to 9 months, showing the superior most position of the uterus within the abdomen. In this slide, you can see the pregnancy at full term, and what's important here is to note the positions of the uterus and full-term fetus within the abdomen and the displacement of the abdominal organs. Now, during the second and third trimesters, the developing fetus is totally dependent on the maternal organ systems for nourishment, respiration, and waste removal. And in order to accomplish this, there are maternal adaptations, and these include increases in respiratory rate and tidal volume, blood volume, nutrient and vitamin intake, glomerular filtration rate, and the size of the uterus, as well as the mammary glands. During the second and third trimesters, you also have release of hormones. You have progesterone. Progesterone is released by the placenta. It has an inhibitory effect on uterine smooth muscles. We want the uterus to be hospitable for the developing fetus. And the progesterone will prevent extensive, powerful contractions in the uterus. Opposed to progesterone, there are 3 major factors: rising estrogen levels, rising oxytocin levels, and prostaglandin production. In looking at the structural and functional changes in the uterus during this time period, the term false labor refers to occasional spasms in the uterine musculature, and contractions are not regular or persistent. True labor results from biochemical and mechanical factors and continues due to positive feedback. And the labor contractions themselves begin in the myometrium, the muscular layer of the uterus. This slide is showing you the factors involved in the initiation of labor and delivery. You can see here at the top there are the placental factors. The estrogens increase the sensitivity of the smooth muscle cells of the myometrium, and they make contractions more likely. Also, estrogens increase the sensitivity of the smooth muscle fibers to oxytocin. It is, and if you look over this chart, you can see that the fetal pituitary, actually the posterior pituitary, releases oxytocin in response to estrogens. And then this sets in motion the whole labor contractions. The term parturition is the forcible expulsion of the fetus, and the contractions begin near the top of the uterus. They sweep in wave-like motions towards the cervix. They're strong, they occur at regular intervals, and they increase in force and frequency. They change the position of the fetus, and they move it towards the cervical canal. The stages of labor are the dilation stage, the expulsion stage, and the placental stage. This picture shows a fully developed fetus before the labor begins and the position. In the dilation stage, it's highly variable in length, but typically it lasts 8 or more hours. And at the start of the dilation stage, the labor contractions last up to half a minute and occur once every 10 to 30 minutes. However, their frequency increases steadily. And late in this stage, the amniochorionic membrane ruptures, referred to as a woman having her water break. And if this happens before the other events of the dilation stage, the life of the fetus may be at risk from infection. And if the risk is sufficiently great, labor may be induced. This slide is showing you the first stage, the dilation stage. Stage 2 is the expulsion stage. It begins as the cervix is pushed open by the approaching fetus, and it completes its dilation to about 10 centimeters or 4 inches. In this stage, contractions reach maximum intensity. They're going to be occurring at this time at about 2 or 3 minute intervals, and they last a full minute. The expulsion continues until the fetus has emerged from the vagina. In most cases, the expulsion stage lasts less than 2 hours. The delivery of the newborn infant into the outside world is the delivery or birth. This slide is showing you the second phase, the expulsion stage. If the vaginal canal is too small to permit the passage of the fetus, it poses an acute danger of perineal tearing, and a clinician may temporarily enlarge the passageway by performing an episiotomy. An episiotomy is an incision through the perineal musculature. After delivery, this surgical cut is repaired with sutures, a much simpler procedure than suturing the jagged edges associated with an extensive perineal tear, which could also result in an infection to the mother. If the complications arise during the dilation or expulsion stage, the infant can be delivered by C-section or cesarean section. In such cases, an incision is made through the abdominal wall and the uterus is opened just enough to allow passage of the infant's head. The cesarean delivery rate had been steadily increasing in the United States for the past 12 years. However, data released from the CDC's National Vital Statistics System showed that between 2009 and 2011, the cesarean delivery rate was unchanged and accounted for 31.3% of all live singleton births. So today we are seeing that it is holding steady. During the last stage, the placental stage, the muscle tension builds in the walls of the partially empty uterus, which gradually decreases in size. This uterine contraction tears the connections between the endometrium and the placenta. In actuality, what is happening is that within an hour of delivery, the placental stage ends with the ejection of the placenta, also referred to as the afterbirth. The disruption of the placenta is accompanied by a loss of blood, but associated uterine contractions compresses the uterine vessels and usually restricts this flow. Because maternal blood volume has increased greatly during pregnancy, the blood loss can normally be tolerated without difficulty. This slide is showing the placental stage, and you can see the ejection of the placenta. Premature labor occurs when true labor begins before the fetus has completed normal development. Now, the newborn's chances of surviving are directly related to its body weight at delivery. Even with massive supportive efforts, newborns weighing less than 400 grams or 14 ounces at birth will not survive. Now, this is primarily because their respiratory, cardiovascular, and urinary systems are unable to support life without the aid of maternal systems. As a result, the dividing line between spontaneous abortion and immature delivery is usually set at 500 grams or 17.6 ounces, the normal weight near the end of the second trimester. Most fetuses born at 25 to 27 weeks of gestation with a birth weight under 600 grams die despite intensive neonatal care. Survivors have a high risk of developmental abnormalities. Premature delivery usually refers to birth at 28 to 36 weeks, a birth weight over 1 kilogram or 2.2 pounds. With care, these newborns have a good chance of surviving and developing normal. In about 3 to 4% of deliveries, the legs or buttocks of the fetus enter the vaginal canal first. Such deliveries are referred to as breech births. Risks to the fetus are higher in breech births than in normal deliveries because the umbilical cord can become constricted and can cut off the placental blood flow. The head is normally the widest part of the fetus. The mother's cervix may dilate enough to pass the baby's legs and body, but not the head. This entrapment compresses the umbilical cord, prolongs delivery, and subjects the fetus to severe distress and potential injury. If attempts to reposition the fetus or promote further dilation are unsuccessful over the short term, delivery by C-section may be required. In looking at multiple births, let's all remember that dizygotic twins are also called fraternal twins. They develop when two separate oocytes are ovulated and subsequently fertilized. The genetic makeup is not identical. 70% of twins are fraternal twins. In monozygotic twins, which are also called identical twins, they result either from separation of the blastomeres early in cleavage or splitting of the inner cell mass before gastrulation. Genetic makeup is identical because both form from the same pair of gametes. However, as we have discussed before, due to some epigenetic changes, the genetic makeup will change throughout the lifespan. This slide is showing you that there are different ways that the fertilized egg can split, and you can have either different sacs. It can be dichorionic, diamniotic. You can have the same outer sac and two inner sacs. It could be monochorionic and diamniotic, or they are within the same two sacs, monochorionic and monoamniotic. And with the fused, you have one here where the dichorionic is fused, and you have one where the diamniotic and dichorionic are separated. If the splitting of the blastomeres or of the embryonic disc is not complete, this can result in conjoined twins. And one of the most famous sets of twins, or conjoined twins, was the two brothers Chang and Ing Bunker, who were from Thailand, which was at that time called Siam. They are genetically identical twins, and they typically share some skin, a portion of the liver, and perhaps other internal organs as well. When the fusion is minor, the infants can be surgically separated with some success. Most of the conjoined twins with much more extensive fusions fail to survive the delivery, or in some cases, only one was able to survive. For some unknown reasons, the rates of naturally occurring multiple births fall into a pattern. Twins occur about 1 of every 89 births, triplets in 1 out of every 89 square, or 7,921 births, quadruplets 1 out of every 89 cubed, 704,969 births, and so forth. Taking fertility drugs that stimulate the maturation of abnormally high numbers of follicles can increase the incidence of multiple births, and this has been seen in this country recently, where there are so many more triplets and twins in classrooms. Pregnancies with multiple fetuses pose special problems because of the strains on the mothers are multiplied. The chances of premature labor are increased, and the risks to the mother are higher than for single births. Increased risk also extend to the fetuses during gestation and to the newborns because even at full term, such newborns have lower than average birth weights. They're also more likely to have problems during delivery. For example, in more than half of twin deliveries, one or both fetuses enter the vaginal canal in an abnormal position. Please view the videos on twins and on fingerprinting, and then proceed to do the twin-to-twin transfusion case.